Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea Westminster Hospital, and I'm proud to be the Vice Chair of BTOG Steering Committee. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and tackle the most important questions that we all face in the diagnosis and treatment of thoracic cancers. It's important to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or the delivery of anything we discussed today. So today's podcast is titled BTOG Does ESTRO 2022. It's a pleasure to introduce Dr. Fiona McDonald, who's a consultant clinical oncologist and friend of the show, also friend of BTOG. Fiona works at the Royal Marsden Hospital and is also happens to be part of our lung MDT. Fiona was at ESTRO this year, and I thought it'd be very useful for us to catch up about what's been going on in this meeting. Fiona, welcome to the podcast.
Thank you very much for inviting me, Thomas.
It's my great pleasure. So we are, like the previous podcast, we are hidden in a room behind BTOG summer meeting in Hammersmith. We have one microphone between us, so we hope that the audio quality is good enough. Tell me about ESTRO. I've never been to ESTRO. I'm a medical oncologist. This is more of a clinical oncology radiotherapy meeting. Where was it? Who goes? What's ESTRO all about?
So ESTRO is our European radiation meeting. So it's not just clinical oncologists. We have a large proportion of physicists and also our radiographers that go predominantly. We do invite med-oncs. I believe Ali Greystoke came a couple of years ago.
Proper doctors.
Yeah, absolutely. And this year we had Heather Wakely there.
Excellent. Heather Wakely being the head of the International Association to Study Lung Cancer. So she's a global figure. Yep. So this is a big meeting.
Yeah, it's a big meeting. It's all tumour types, much like, so where you've got ASCO and ESMO, we have ASTRO and ESTRO. ASTRO being the American version and ESTRO being our European version of the meeting. So it covers broad topics like new technology, so protons, and that can be across any tumour type. So lots of physics, lots of motion management solutions, which our radiographers who deliver the radiotherapy need to be up to date in. So multidisciplinary, and then within the different tumour types, we get updates whether it's radiotherapy across the board or specifically in lung cancer.
And is this where the big radiation oncology based studies will produce their data? Is this a kind of premier location, or would they produce them at ASCO as well, or is this kind of?
Yeah, I mean, it's a bit of both, to be honest. It depends. If you've got more of a multidisciplinary result in a multidisciplinary trial, you'd probably take it more to the ESMOs and the ASCOs. But when it comes to some of the more technical data, like sub-studies, for example, of 0617 looking at IMRT or something like that, you'd very much take it to a radiation meeting, because we've got the audience there with the physicists and the radiographers who deliver the treatment as well as the clinicians. So it really depends on the topic of the work as to which meeting you'd pitch it at. Gotcha. But it's very well attended across the disciplines that are involved in
and where was it this year?
Where was it this year? Where have I been to?
Can't remember where it was.
Copenhagen. Sorry, I've been to
Copenhagen.
Milan since. I'm getting confused. Copenhagen.
Copenhagen it was. So in lovely Copenhagen, what do you think were the big hitting results? What stands out in your memory?
So I think the most important, albeit it's small late data, is from the SABRE COMET trial. So for those of you who haven't heard of the SABRE COMET trial, it was initially presented a few years ago, and this is a study looking at the addition of stereotactic radiotherapy to standard of care, usually some form of systemic anti-cancer therapy, in patients with what we call metachronous oligometastatic disease.
Okay, I'm going to stop you there.
Yeah.
So oligometastatic, not many metastases, usually defined as around 3 to 5.
Yes.
What number were they using?
They were using 5. 5. But in reality, I'll come back to this, but in reality, the majority of the patients went in had 3 or fewer, even though up to 5 were allowed. So for our audience who are paying careful attention, this is non-small cell lung cancer, metastatic. No. SABRE COMET was any tumour histology.
Any tumour.
Any tumour histology, but metachronous implies that the primary plus or minus nodes are controlled and the METs have appeared later on. So it's not synchronous oligometastatic disease when the METs found at the time of diagnosis. So you've had your primary treatment, you've done well for a period of time, usually in some trials 3 months, some trials a minimum of 6 months disease-free interval. And then at the point of relapse, it's only limited relapse with up to 5 sites of disease. And it could be prostate, it could be breast, it could be renal cell. But there were a proportion of patients in the trial that had non-small cell lung cancer. And these patients were randomized either to the standard of care, which could have been hormones in breast cancer, but in our non-small cell lung cancer will have been chemotherapy. This probably was may not have had that many actually on IO. I don't know how many did.
So when we're interpreting this in terms of our lung cancer patients, we have to be careful because it's a bunch of different cancers.
Yes.
But it's using the concept of if a cancer is progressing in a limited number of places and the patient remains pretty well, because these are trials patients, is there a benefit of trying SABR?
Yes. So it was randomized between just the SACT or standard of care or the addition of SABR to that backbone of SACT. And we know the initial results from previous years. So it was a phase 2, and it had a design that was what called a relaxed alpha, allowing us to also power it for overall survival. So in the phase 2 setting, it shows a significant progression-free survival advantage and overall survival advantage, despite the fact small numbers, relaxed alpha design. So the data that was presented at ESTRO was the data at kind of 5 years and beyond. So the late data, so albeit it's small numbers because it's the late survivors, but the median progression-free survival was 12 months versus 5.4 months in favour of the addition of
so more than doubling.
Yes.
Okay.
And also for the median overall survival, it was 53 versus 28 months.
And this is just lung cancer patients?
No,
these are all patients?
This is all patients across the board.
And excuse stupid question, because as you know, I'm a medical oncologist, I don't understand these things. SABR, what's the difference between SABR and CyberKnife?
Ah, interesting. So we get that a lot actually from our patients. So I often say to my patients that it's kind of like the difference between an Apple Mac and a PC. So the machine you deliver it on is different to the technology or the software that you use to deliver the treatment. So CyberKnife is a machine that is very good at delivering stereotactic radiotherapy, the highly conformal technique, allowing us to deliver very high doses to small lesions safely. But it's not the only platform of delivery. You can equally deliver stereotactic radiotherapy on a normal linear accelerator, as long as you've got the right all singing, all dancing fancy tools. Now, when I say that, we have both available at the Marsden where I work. We tend to do the majority of our lungs on a normal LINAC, just because we get very good visibility with our cone beam CT. We do elect to use our CyberKnife. You can use a normal LINAC, but we do elect to use our CyberKnife for certain lesions like spine, because the tracking ability of the CyberKnife, we have more confidence with the spinal cord. So,
but the SABR we're using here is a technology that should be available in the radiotherapy department of most people listening to this podcast.
So very interesting question there, Tom, because until fairly recently, we had limited centres, certainly within England, that were commissioned to deliver this. And although we've been, campaigning for this to be rolled out across the country, it wasn't really until COVID hit that we had the mandate to roll this out across the country. So one of the pieces of work that myself and a number of others have been heavily involved in is helping roll this out with the education that requires these techniques around the country. And the first site to now be commissioned throughout the country is the ability to treat lung lesions. Now that includes now primary lung lesions can get SABR in any radiotherapy centre, but also lung metastases, because it's the same sort of technique. And
the technologies there is a commissioning there. This is supported by NHS England or whichever devolved nations commissioning there is.
So since SABR Comet reported, and since we've had the results from our UK-based registration study, the CTE, this is now commissioned in metachronous oligometastatic disease, commissioned up to 3 sites of metastases, rather than the 5 that were included in SABR Comet, because the vast majority of data is on the 1 to 3, and that's regardless of tumour type. It is only in metachronous, not synchronous,
Yeah.
so not at the
Yeah.
same time as you've got an uncontrolled primary. And rolled out across the country is the ability to treat lung mets. Many centres can also treat other sites like spines and adrenals, but we're not there yet with the whole rollout. That programme is continuing.
But from the point of view of people listening, how will or could this change practice? This could change practice in the patient who is on systemic therapy for their lung cancer. They are well. The majority of the cancer has progressed, but there is up to 3 areas which are growing. And in that scenario, we know that there's...
No, you're now talking about oligoprogression, which is different. That's the whole, which we can come back to. So this is at the point of relapse. So these are patients that have had their primary dealt with. At the point of relapse, regardless of your histology, in an MDT, we need to be looking at the pattern of relapse. We know the vast majority of patients have got systemic anti-cancer therapy options, and I believe that's true across the board for tumour types, not just in lung. But the question is whether we should be adding in at that time point
to systemic therapy as well.
Yes, at the point at that point of relapse, if it's limited and 3 or fewer lesions that are all suitable for stereo.
And suitability is size or location or both?
Both. So in general, it's small lesions. So in general, kind of up to 5 centimeters, it is kind of.
And does that include brain?
So brain is different. So brain has been routinely commissioned for ages. So the reason brain was explored many years before this whole extracranial thing, mainly because of the kind of chemotherapy sanctuary site it's always seen to be. So it's standard of care as long as you fulfill the NHS commissioning. It's been that for ages to get the SRS to the brain. So this is really talking about extracranial oligometastatic disease.
And do you think Sabre Comet changes our treatment paradigms? Will you and I be treating our patients differently in 6 months' time based on this?
Not on the up-to-date data, because we're already doing it. The reason the update at ESTRO was interesting is that we are seeing that the benefit is continuing with longer-term follow-up, but also importantly, there were no additional grade 3 or higher toxicities, which is important when we're talking about improving survival of patients, that we're not leaving them with morbidities. And there was no impact on quality of life with the addition of this treatment as well, which I think is important. And there was reduced rates of subsequent need for palliative radiotherapy. So that went down from 70% down to 24%.
Oh, right, okay.
And although there were similar rates in both arms with this long-term data of subsequent systemic anti-cancer therapy, there was less of that being chemotherapy.
Any quality of life data?
Yeah, no impact on quality of life. And that holds out now to this kind of beyond 5 years data. So I certainly think, and this is not specific to lung because the trial isn't, that we need to be at the first point of relapse, not just saying this is metastatic CMED-onc, SACT alone. We need to be looking for these patterns of oligo.
Which fits in with our BTOG championing of the MDT, which is when your patient progresses, have a discussion with your colleagues, make sure that whatever you're considering, you've considered all facets of treatment. Okay, so that's Sabre Comet. Big news, everyone very excited. Any other highlights in Copenhagen whilst you're trying to remember where you were?
So one of the other things which was nice to see was some UK data presented, and there was a lovely presentation by Patty Diaz, who you probably don't know, but she's an absolute guru. She is one of the team from our radiotherapy quality assurance group based at Mount Vernon, and she's been working along with others, has been working very hard on helping with this UK Sabre rollout program.
So this very much follows on from what we talked about.
Exactly. So she was presenting some of the data on the lung Sabre rollout, which covers lung mets, but also is relevant for the sites who hadn't yet started doing Sabre for early stage lung primaries in those that weren't having surgery. And a massive amount of work has gone in. So centres that weren't doing it were matched with centres that have been doing it, and there's this whole mentorship scheme going on. And then there's cases that go out. So it's your kind of contouring case goes out. And then the clinicians have to contour not just the target, but all of the important organs at risk to make sure we're delivering this high dose radiotherapy safely. Then that gets resubmitted. It then gets scored by an experienced clinician along with a member of the RTTQA team. And then feedback to the site as to whether they've passed or failed, and some education tips, plus or minus a bit more mentoring before the resubmission. And then on the resubmission, the aim was to hopefully have everyone passing that aspect. That was also repeated for the planning, which is the physicist bit. So after you've got the contours on, you then give it to the physicists, and the physicists have to do this technical radiotherapy planning. That gets submitted, and again, feedback and critique. So vast amount of work to ensure radiotherapy quality assurance with this rollout.
And this was multi-site across the whole UK?
Yeah, in England.
Wow. That's a huge undertaking. And again, a stupid question from a medical oncologist. I assumed that when someone contoured something, whether it was you or a colleague 200 miles away, it would be the same, but clearly not. Clearly, there's a variation in interpretation. Is it interpretation of normal structures? Is it interpretation of tumor, or is it an interpretation of what should be covered and what shouldn't be covered?
It's difficult. It's probably a combination of all of those things. I think what it really highlights is this is not a straightforward technique, and there are certain organs at risk that for locally advanced disease, which is where we're normally doing our technical stuff, you don't need to contour. Like, we're not worried about the bronchial tree, for example, in our conventional radiotherapy, because it's the tolerance is above the doses we're giving, our kind of 60 and 30 type doses.
Okay.
But as soon as you get to stereo, it's all about what we call point doses matter. So where are you delivering that pixel, or maybe just a bit bigger than a pixel? Where are you delivering those really high doses? And if it's over like a tracheal wall, for example, are you overdosing it and running the risk of fistula or hemoptysis or whatever? So unless you're outlining these structures that we're not used to outlining, unless you're outlining them accurately, your physics plan is not going to pick up.
And normally in normal practice, there's no review of this. This is just done by the clinician, and one hopes that it's as good as it can be. Yeah,
I mean, so in normal practice, we've highlighted via the Royal College of Radiologists that peer review does pick up some changes that are suggested. So more and more across the country, peer review is happening to sign off contours. And of course, it's a large part of the day job is training the registrars and reviewing the registrars' work, so they're able to do this. But if you've never, as a consultant, if you've never outlined, for example, the brachial plexus, or you've never outlined the proximal bronchial tree, it's kind of learning to do that. And if we've only got kind of one case to get it right before you're then able to do it, it really highlights the role of radiotherapy quality assurance, and highlights the work we do in the UK to make sure these new techniques are rolled out robustly.
And what did this study show? What was the results of the presented at ESTRO?
So a number of things, but I think the most crucial one was that the particularly the normal tissue contouring was a very high failure rate for first submission.
Wow.
But that subsequently, with the mentorship, etc., we have been able to commission every centre. So I think it's not to say that everyone should have been able to pass first time if it's a technique you've never done. But it really highlights the role of what the programme has provided, which basically involved every centre. You're either a centre trying to learn, or you're a centre mentoring, or the vast amount of work that the radiotherapy.
I mean, this is brilliant, because this is exactly what we should be doing. We should be making sure that people undertaking treatment have the expertise to do that. It doesn't sound like there was, but was any resistance or reluctance for people to be part of this? Or did people get offended that their scans plannings were being looked at?
It's interesting. I was one of the scorers.
Yes, you're on the right side of the table.
I don't necessarily think I get to hear the moans and groans when they get their reports back. But I like to think that, like I say, we only have one chance and one case to kind of, with an iterative process, to get this right. And if people were upset by it, it's just got to come down. If you're a scorer, at the end of the day, it's about patient safety. So if people are upset with me and the other scorers, as it were, that's kind of fine. we've just got to take that, because we have to ensure that robustness.
And do you think this is applicable more widely? Do you think it might lead to a different way of peer review, whereby should happen, I guess, in medical oncology, which is, who knows if I'm describing things correctly? No one's really watching. Are clinical oncologists ahead of the game, and is this beginning of a way of maybe making sure that someone remains on track?
Potentially. I mean, I think peer review is not performed everywhere, and I think at the end of the day it comes down to resources and job plans, and it is kind of duplication of work. Two sets of eyes when traditionally has only been one. Where does that additional resource come from? But it's something to strive towards, certainly. And as we see in our MDTs and the discussion we've just had at BTOG, which I know on the podcast you weren't there, but how complicated MDTs are getting, for example, in this stage 3 setting. In MDTs, being challenged by someone of your own specialty, is good, and we don't necessarily have the luxury all the time in all the MDTs of always having 2 surgeons, 2 med-oncs, 2 pathologists, 2 rad-oncs, so that you get that peer-to-peer pushback, I guess.
I'm a great believer that actually, if you have someone else in the room of your same speciality, I think we all up our game, if we're being honest. Okay, so that's Saber Comet. You're talking about the quality assurance data. What about earlier stage disease? You largely focused now on more metastatic. Was anything tickle your fancy in the early stage or locally advanced disease we should know about?
Yeah, so locally advanced disease, I think it's nice. Again, it's nice to highlight UK work. So some really interesting data coming out of the Christie to do with work on cardiac constraints. So I think since RTOG 0617 came out a number of years ago now, so that was the study looking at escalating dose in stage 3 disease, escalating radiation dose.
I remember this because I think I heard it in Australia. I think it came out then, and I remember that the higher dose was associated with a worse outcome.
That's right.
And there was much head scratching.
Yes.
As to why, if you increase the dose, okay, maybe it wasn't more effective, but why was it worse? And then my limited understanding, it's to do with the fact that it wasn't the radiation was causing less effect on the cancer. It was comorbidities, effect on cardiac function appeared to be the concern. Is that right?
Yeah, I mean, there's a number of issues with it, which I won't go into the detail of, but one of the issues seems to be cardiac dose. So we've been worried about lungs for ages, and they've got very strict constraints. This whole kind of encompassability thing essentially comes mostly down to, can you meet the lung constraints as well as the cord? But the kind of cardiac constraints are a bit more optional. The esophageal constraints are kind of optimal but not mandatory. And now we're far more concerned about the heart. But then the question comes, well, what should the heart constraint be? If we need to bring the heart constraint down, how do we get that balance between avoiding avoiding morbidity due to cardiac dose and mortality due to cardiac dose, against not treating patients radically enough so they're then dying of their lung cancer? So where do we set that constraint? And clearly it's going to be an enormous challenge to try and do that in a randomized trial, given everything else that's going on. You've got your LAURAs, your ADORAs, you've got so much going on in that space with the drugs. How would you ever, changing one kind of seemingly small thing, how would you ever work out whether it was the right thing to do or not? So the team at the Christie have done an immense amount of work looking at large data. And essentially one of the important pieces of work they've done, which was presented previously and updated at ESTRO, is taking like masses and masses and masses of patients who they treated radically, and then looking at what we call the dose cube. So that's, if you imagine a kind of generic chest, if you imagine everyone had the same anatomy and the same chest, and you kind of put the dose on it of where it was hitting what, the heart, the lungs, the esophagus, and then you correlate that a massive amount of data in hundreds of patients to mortality. It's essentially identified that it's the base of the heart rather than anywhere else.
Base as in apex?
The cranial bit.
Cranial bit.
Okay. Bit, that's
top of the heart.
Yeah. But otherwise known as the base. But it's slightly confusing.
Not how I think of it, but I understand what you mean.
Okay. So we don't know whether it's the coronary, to do with where the coronary arteries come out. We don't know whether it's to do with like sinoatrial node. We don't actually know that it's actually a heart structure. It could all be to do with the blood flow and the lymphopenia. So something around dose there.
And was that a surprise? Would you have expected to be more about ventricular dose? Or has it always been known that that part is particularly sensitive? No,
not at all. But these large data sets have identified that that's the bit that if you irradiate correlates with mortality, not necessarily cardiac mortality, which is why it could be partly lymphopenia. Now with all we know about the immune response, etc. So what they are now proposing to do, because they've got large numbers of patients coming through their Greater Manchester patch, is they've kind of done planning studies to try and find that compromise between being able to treat enough patients radically and yet being able to meet a constraint. And they've they're going to set a constraint and then use a kind of iterative process on big data and population time. So you've got a bunch of patients up till now who've had the standard constraint that they currently use. Then the next chunk of time, they use this new constraint, and then they look at the outcomes. Is it the same, in which case they've done no better? And then they iterate and say, well, do we bring the cardiac dose down? Or are we already seeing the survival going up? So it's just quite a clever way to try and assess new technology in a big data where you're never going to get a randomized.
So we're never going to have another RTG0617 because we have too many other variables. It's been there, done that. But now that dose of radiation is going to be pretty much fixed. No one's going to really change that. But if we can change the way in which it can be given,
how we plan it.
Then
dose has to go somewhere. You don't want to spare the heart and dump it in the lungs. So it's trying to work that out, and it kind of feeds into, if it kind of potentially then feeds into other trials like with protons, where you might be able to heart spare a bit more because of the dose distribution. So it's just really interesting big data.
So this may not change what we do now, but it informs on future studies, and it may well be in the years to come, the radiation plans you are giving are going to avoid, for example, base of the heart. Because it transpired that was the trouble. And that might minimize reduce, one hopes, mortality for whatever reason, whether that is side effect related or cancer related.
And all the more important as well, because in the last year, 18 months, 2 years, I get lost with time in COVID, we've had the lung art trial come out, the post-operative radiotherapy, which again showed that the mediastinal radiotherapy was associated with mortality, even though it was helping with local disease control. So again, more concerns raised, whether post-op radiotherapy is still going to be part of the paradigm. We've heard today, what are we going to do in an R1, where at the moment the access to adjuvant IO, chemo IO is still going to be for the R0s. So port hasn't gone away completely, and so it might feed. The heart constraint is probably the heart constraint, whether you're treating post-operatively microscopic or whether you're treating stage 3. So learning more about what the heart dose is doing, what we should try to optimally constrain it to, is going to be really important.
Brilliant. Well, I've learned a lot. I always do. Tells you how little I know. Thank you, Fiona, for giving us the highlights of ESTRO. And we look forward to hearing another update next year. I've just booked you in. So thank you very much to the audience for listening. As mentioned in previous podcasts, we are updating how we do our podcast. I'm going to be joined shortly, I think probably for our next recording, by my colleague Leanne Castle, who is a respiratory physician from Barts and London Hospital. And we're going to do 2 interviewers and 1 interviewee from here on. But thank you very much for joining us for this podcast, and we very much look forward to you joining us for our next. Bye-bye.